if you can't work with your therapist, it's not going to work. Don't try to force it if it's not working, because we can talk about why it's not working, and I may not be the right person for you, and that's fine. We'll find somebody else who's better. The hardest thing you can ever do in terms of therapy is pick up the phone and making the first call.
Welcome to Just Healing, where we rediscover humanity in our conversations around trauma and celebrate all the unique ways we love and heal.
Welcome to this next episode of Just Healing. We have a very exciting episode. I thought this one was timely because of all the things that are happening, but I will let this person introduce himself because his name is cool as hell. First of all, his name is Dr. Matt Love. Who wouldn't want to go see somebody with that name? But Matt, why don't you tell people who you are, your area of expertise, so that they can get to know you?
Sure. So thank you very much, Deborah, and thank you for having me on. So I'm Dr. Matthew Love. I'm a licensed psychologist, and actually, I'm over here now in Connecticut, but trained back out in California. And the areas of expertise are I primarily work with individuals, males, females, with anxiety, depression, as well as some bipolar disorder, as well as ADHD and some learning disabilities as well. And then in addition to, I also work with survivors of child sexual abuse, and helping mainly males understand and process that incident for themselves and also heal from it. And then in addition, I like to mix it up here. Is I also do a lot of sports psychology as well, using cognitive behavioral therapy, rational emotive behavioral therapy, because it's nice to have a good balance in terms of how you treat and what you treat with people, so that you can stay fresh and engaged. And then if that wasn't enough, I also do psychological evaluations, both with personality psychological evaluations, as well as also learning disability, autism, and some other various neuropsych testing as well.
Yeah, we've done some tag teaming on some cases.
We have, yes, yeah, oh yeah, forensic consulting and chart review. The fun stuff.
The fun stuff that people don't realize goes on behind the scenes, right?
Right.
One of the interesting things about you when I first met you, I was your professor, which blew me away because you were so far advanced than your other peers. And I hope they're not listening. I'm not trying to offend you, but you were. And so we used to have to go to these sites and visit and make sure you weren't doing bad things. I remember I came to your site one time because I was like, why am I going here? It didn't make any sense because you guys had it.
Yeah, that group that we had there, I think every single one of them were pretty advanced.
Yeah. 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 We had group supervision and we would talk about everything but what we were supposed to be doing.
Right.
Yeah. And it was so fun. And what was interesting was that how you wove your personality into it, and you came and talked at IVAD or something, and I didn't even know you were doing the work that you were doing on male sexual abuse survivors. And
Mm-hmm.
I was writing my book at the time, and I said you have to write the chapter on the vampire myth, right?
Right.
And a lot of people don't know what that is. So can you explain the vampire myth so people get it?
Yeah. So it's a term that we find in psychological and in terms of trauma, just discourse, where it really helps to kind of describe the stigma that a lot of males and trauma survivors in general can feel is when there's a particular incident or boundary violation that has occurred to them. There's this fear that somehow they've been infected or they're somehow now tainted with whatever has occurred, and they are going to now be, you know, destined forever to live in a certain way, and it's a foregone conclusion that they may either become that they're somehow damaged, or somehow they're going to go and affect other people, and that survivors of abuse, and sexual abuse in particular, are going to become perpetrators and are destined to be that way, and that can be very damaging for especially a survivor of child sexual abuse, but also with men too, because a lot of times unwanted sexual touching, whether it's from a male perpetrator to a male survivor, or even a female perpetrator to a male survivor. There's a lot of complexity that goes on with that because you're interweaving the idea of masculinity and what does it mean to be a man, and if this has occurred to me, did I somehow want it? And there's a lot of also stigma around if it's a male perpetrator against a male survivor. It's not uncommon the survivor has a lot of shame and guilt because they think I'm a man or I'm a boy, because we know typically it's around 7, 8, 9 that a lot of times this happens where they think I should have been able to fight off the attacker. I'm a man. I've been taught through society that I'm supposed to be powerful and strong. If this happened to me, then that clearly I must have allowed it. And also, what does that mean? Did the perpetrator see something in me? Did the perpetrator know that I'm gay? And maybe the survivor is gay, maybe they're not, but they may have that thought. And at 7, 8, 9, that's rather complex. And then oftentimes too, you see in response to that is hypermasculinity, hypersexuality, especially when it's a female perpetrator to a male, is they may try to be they may because also if the society says, oh, older female is interested in a younger male, that's a great thing, but as a boy or a teenage boy, you don't really understand what the hierarchy and the power and dominance and all that. And so a lot of times there is a hypersexuality in that case, and the male survivor is attempting to, understand or kind of recreate the similar experience, but not so that for his own exploitation or manipulation of the other, but kind of trying to overcome whatever had occurred for him and trying to rectify or heal. But it's just a maladaptive way of doing it that really becomes detrimental because the male survivor, for the most part, it doesn't actually satisfy whatever loneliness or perceived emptiness and intimacy that they're seeking. And when it's a male perpetrator too, more often than not, if it's a male perpetrator to a male survivor, the male survivor isn't going to go and talk to mom or dad about it or whatnot. The majority of the cases that we do see, it's because the child has gone to the ER because of injury, whether it's physical injury, alcohol intoxication, whatnot, and there's a lot of embarrassment and shame. And so with the vampire myth, they feel also with that shame is that idea is like, because this has happened to me, I'm also going to do this to other people, and that can lead to a lot of suicidal ideation. It can lead to a lot of idea that I should go and withdraw and keep myself away from other people and never get close to them. And so it'd be pretty from a longitudinal perspective, very impactful in a negative way.
Right. And a lot of that research is based on flawed data, right? So a
Right.
lot of times people who are incarcerated and they do the research, they're doing it on incarcerated people. Most male survivors will not hurt someone else because they never want anyone to feel that pain, right? And so if you already have people who are incarcerated, your data is going to be flawed. And people don't realize that that is a myth. It doesn't happen, right? And the people need to understand that you can't just lump people into a category because of all of the false information that's out
Right.
there, right?
I completely agree. They do lump many of the male survivors into you're clearly antisocial. There's no hope for you. You're going to be incarcerated because you're right. That's where primarily the data is from because men aren't talking about it. There's a major stigma, and if a man does talk about for female perpetrator male, their buddies are probably maybe high-fiving or cheering them on, but they're
Slapping them on the back.
failing to realize that this is a very confusing period for the individual, even if they're older and it happened to them at a younger age. They don't know how to process that, and then if it's a male perpetrator, to a male survivor, regardless of your gender identity or sexual identity, there's a lot of shame tapped around that as well. How did the you know person know something that I didn't know, or
What was it
also,
about me? You
was it
know?
about me? Yeah, exactly. And so you're right. The majority of men are, protectors and that have experienced this, and you can see that in the way that they, interact. They're very kind. Yes, they are hyper alert and hyper vigilant, but it's to ensure that this doesn't happen to another person for the
Right.
most part. And that's really the main thing, is to try to break down and dismantle this vampire myth that all men who have been abused will be monsters, because it's not the case. And this may or may not be controversial, but this came to mind just now, is when we see in present day, and I 100% agree that the individuals who have you know been brought to light during the Me Too movement and everything, certainly were horrible individuals, and there was prosecution that was required. I think it also really put a lot of men who have this worry that maybe they have the potentiality of doing this. I think this shut them up a little bit, because they weren't really seeing that, if I speak up, or if I've done, if, you know, if I speak up about the prior abuse, will I be accepted? Will people believe me? Because right now it's been viewed that all men are, for the most part, vampires,
Right.
and it's not the case.
And it takes men up to 20 years to disclose, right?
Right.
And so they carry around that shame and guilt. But also, as a treatment provider, because your background is so impressive, and I had a part in that, and I, can't get the gushies. But you do a lot of different types of treatment, and you also match that to the client. But how does that work when you have a survivor that comes in your door? Like, what do you hope to give them, and what should they look for?
Yeah, I mean, I think number one is when I'm treating a male survivor, is first and foremost understanding is that I'm probably the first person they've ever really said this to, and in my experience, the majority of the times it comes up, it's not like they're coming in, sitting on the couch the first day and saying, "Guess what? I was a male survivor of child sexual abuse." They're coming in for some other interpersonal issue, whether they have a child and they're failing to connect, they have a significant other and they're not connecting, they're not moving up in the career, whatever it is. And then through talking with them, you you just get a sense that there's something more going on. And that's when more often than not, I just ask the question: is has anybody ever touched you in a way that made you feel uncomfortable? And a lot of times, more often than not, it's a yes. And it's really about just respecting where they want to go with it, because a lot of them don't want to talk about it, and that's fine. And to force, especially with male masculinity, is you don't want to force them to talk about it, because they need to feel like they're in a position of power with it. And also to say, it's not your fault, or you couldn't have done anything differently. That's very kind of takes away their power as they perceive themselves as a man. And so it's more saying, you know how have you grown from it? How is this, how have you interpreted this situation as well? And from a treatment perspective, certainly using process-oriented psychotherapy. What does that mean in layman's terms? It's just getting the person to talk about it at any rate that they want to talk about it, and whatever they want to talk about. And sometimes I work with some, I had client a couple of weeks ago saying, I don't want to talk about this. I don't want to go closer to it. But we use it as a touchstone to help maybe explain how their interactions were, their interpersonal interactions were happening today, and over time they get closer and closer to it. So it's really respecting that, allowing them to get close on their end, and using cognitive behavioral therapy as well to help them make sense of it. What does it mean to them that this occurred, as opposed to saying, somehow you're flawed, or you allow this to happen. It's like, well, what does it mean? This happened, and acknowledging that it happened, but focusing on that growth aspect. What is it? How do you want this how do we build this, take this as a foundation and build up from it, rather than saying that we're
Right.
damaged?
And for people who don't know, cognitive behavioral therapy is basically your thoughts and your behavior go with your actions, and changing those thoughts changes your actions, right? So you match the feeling and the thoughts together. And you mentioned REBT therapy. Now there's a distinction there between them just a little bit. And
Right.
what is that, so that people are like, what's REBT, what's CB, we're saying all these different things, so tell people what that is.
Yeah, so like with rational or RBT, rational emotive behavioral therapy or RBT, and I got training at the Ellis Institute in New York City, where Ellis is the guy who designed it, and interesting enough, it was developed before CBT. He wasn't a part of UPenn like
No.
Beck, so he just never really did any research until later in life with it. But basically, what it is that the you have four core beliefs. You have should statements or very inflexible all or nothing thoughts. You have catastrophizing, which this is the absolute worst thing in the world. You also have intolerance to frustration, and also self-doubting, which really basic self-doubting, which is basically you're rating yourself more or less than others. And the whole idea of it is that you don't walk around doing this all the time, but there's specific situations that it causes these core beliefs to come forward, and really helping you identify when this core belief occurs. This activates anxiety for me, or this activates depression for me, and I should, and then and how do we move it from anxiety to a worry? Because we first and foremost want to understand and that the reality is that whatever it is could occur, and we don't want to discredit that, but do you need to be anxious? Is this really the most horrible thing in the entire world that could happen? Is there anything else that could be worse than that? And it's about restructuring those core beliefs so that when you have a thought about, in this case, an unwanted sexual experience as a child, what is that core belief? Is it a self-doubting belief that comes up? And how does that serving you? Is it helpful, not helpful, or something else? And how do you, while respecting that this occurred and this is traumatic, and making sure that the client understands that you're not invalidating that experience. How do we structure it so that our relationship with the experience starts to change and grow, so that it's not always eliciting that depressed or anger or resentment. It's causing it's a sadness or a grieving for the child who was at that point,
Yeah.
and how you can move forward. And then it focuses on the behaviors and whatnot, but it's really belief focused, and the beliefs, how the thought impacts the core belief, which then impacts the emotion. And so I try to practice that way, mainly because it also fits more with my style and personality. I have to tell clients that if you're here for the fluffy bunny therapist, I'm probably not that. But if you're here for the guy who can probably help you, and it's going to be conversational, and where it's like you're meeting the guy on the street and we're just having a conversation, I'm probably the psychologist for you, but it's not going to be easy.
Right. And one of the things that people should do is shop, right? Because there's all these different disciplines. You have school psychologists, you have marriage and family therapists, you have LCSWs, right? You have counselors, right? And you have psychologists, and they do different things, right? But why don't we talk about those distinctions? Because sometimes people shouldn't go see a certain type of person for the type of treatment, right?
Right. And with that said too, if so, a psychologist and a psychiatrist are both doctorate level individuals, and those are their terminal degrees, meaning you have to have that degree in order to practice. So the difference between a psychiatrist and a psychologist is the training and background. One's medical school or osteopathic medicine school. A psychologist is typically a PhD or PsyD, same basic degree. You're just, as a PsyD, you're practicing and getting training clinically from day one. A PhD, you wait a little bit, and your training program is the doctorate level. But you're both licensed psychologists at the end of the day, so you go through an internship, a postdoc, many hours of supervision, and then also you must also maintain continuing education credit as well. And so this clinical psychologist is going to be the one who's MDs aren't going to like this, but are pretty much on par with a psychiatrist, except for doing medicine and prescribing. You also have counseling psychologists who, there can be licensed psychologists, but they just aren't going, and they're not having the specific training in the severe pathology. And so counseling psychologists, I'm sure, are great, but if you know that you have schizophrenia, bipolar disorder, or whatnot, you may want to work with a clinical psychologist versus a counseling psychologist, simply because the clinical psychologist will have a little bit more exposure and training to that. LPC, or licensed professional counselor, I used to hold that license before. Um, at least in my training, it was fantastic training in terms of humanistic and existential psychotherapy. That still impacts my practice today. But they're master's level clinicians, and that's the terminal degree for them, even though some may have a PhD. That really just affords them the opportunity to teach on a tenure track in university. Same thing with social workers. The master's level is the terminal degree. Some have a DSW, but really that's just allowing them to be tenured for the most, from my understanding, in a university setting. So yes, they go through a little bit more training and whatnot, but in terms of expansion of scope of practice and what they're capable of doing, it's still, the doctor doesn't really afford them any more expansion of their scope. And then you also have marriage and family therapists who primarily focus on the family systems theory and whatnot. And with any of these degrees, not everyone's going to be the right therapist for you or psychiatrist for you. And just because they have a degree doesn't mean that their training was the same. So you really kind of want to get a feel for them, because at the end of the day, if you can't work with your therapist, it's not going to work. Don't try to force it. And like I tell every client, tell me if it's not working, because we can talk about why it's not working, and I may not be the right person for you, and that's fine. We'll find somebody else who's better probably for you.
Right. And you can shop. I tell
Right.
people, try 2 or 3 out and shop. And there's also one we missed, the school psychologist, because we were recently talking about this. They are master's level people in the school setting, but they are not licensed doctors, and so they do assessments in that setting, and so that's a different scope, because they're acting within a role, right? And each of these people act within certain roles. Like social workers, go out and look at the system in the community. Like, there's different things, so you have to find the right match. Not that any of these people can't help you. They just may not be the right thing for you for what you're talking about. You need to make sure you get someone trauma informed. But the biggest thing is fit. If you don't fit with the person, you're not hurting that provider's feelings. And what the provider usually should do, I call it the soft handoff. I help you find someone that fits with you. I might meet with you and that person if that's what you want to do, but I do that one time. And I make sure there's a fit level there if you're seeing me, so I can transfer you over. But you don't just go find the first person in the phone book, because it might shut you back down if they don't know how to approach you.
Right, exactly. And a lot of times too is, if the provider, misunderstands something and they say something, or they ask you a question that does cause you to shut down, tell them. They're not going to be offended.
No,
Well, let me rephrase it. Any good therapist won't be offended. I don't know
no.
about.
No, they won't be offended. And, even a psychiatrist, they prescribe meds, and then the psychologist deals with all the feelings. And usually they work together. Usually that's how it's supposed to work. Sometimes they don't. There are a few psychiatrists who actually see patients. And I find that effective for a lot of people if they're prescribing the meds. There's nothing wrong with that. But you just have to find a fit that works for you, and make sure that, you're okay with being open with them, because it's going to take rapport. You can't just come in and do that. It's a rapport building, and they know that too.
Hmm. Absolutely. I mean, they know that it takes time, that, they're going to try to push you along if you're sitting there twiddling your thumbs, because at the end of the day, you know, you're there for you. And if you're not ready, the best thing you could ever do is just be honest with the therapist.
Right, because if they practice out of their scope, that's harmful, right?
Because, if they don't understand the intricacies of child sexual abuse or trauma in general, or if they do a one kind of shot thing of, and I oftentimes I'll say you should probably go do EMDR, you should go do, another modality, and then people, it's not uncommon to say, well, can I still see you? Yes, but we have to coordinate that. I'm not going to do EMDR with you. I don't do the EMDR, but you should absolutely go do it. Or if it's you need to go do TMS, or for the anxiety, or you need to go do X, Y, and Z, or whatever it is. It can be collaborative process as well, but you can't expect the therapist to be able to do everything.
Right, and we can't do everything because then we'd be out of our scope. We'd be doing harm because you can't focus on everything. We need to stay in our lanes. And if therapists are doing that, oh, I can do EMDR. Oh, I can do this. You can't focus because your treatment plan is for one specific problem you're working at that time, and then you update the treatment plan, and people don't realize that we have treatment plans, we have notes, and we're supporting all of that with documentation. You can't be doing everything in the book. Like, you shouldn't have the same family therapist as you have for your individual therapist, because that individual therapist is for you, like, and so there's a lot of people who do all of that, but unless you're in a community-based setting where they can't afford to have more than one person, you usually do not do that in private practice. So
Correct. Right. And that just takes also the provider of really getting to know who else is out there, who else do they trust, and
yeah,
trust with their clients to do good work as well.
absolutely. It's a lot. Like, being a provider is a lot, but I think the survivor coming into you is doing all the work. You know what I
Right.
mean? And you never see the back end of how hopefully they've grown as a person, but it's the work that they put into it that can be quite beautiful. When you get a good fit. You know.
And that's the thing too. You mentioned we don't always see the work as a provider. People typically end therapy and they still have growth going on, but we also don't know how they've gone. Sometimes they end because they feel the symptoms have reduced or whatnot, and they go on, they live their life, and you don't see them ever again, and you
Right.
don't know what's going on with them, and that's something that it's a little, it's too bad. It would be nice to take somebody all the way through, but at the same time,
And you don't know what seeds you've planted. Like, sometimes I see people years later, and it always makes me smile when they're doing well, right? And some of the people I work with, I kind of go, ooh, 'cause
right,
I see. I'm like, okay, well, you're not there yet, but that's okay. That's their journey. That's the thing, is that we're like, well, that's your journey, and you'll figure it out, and that's the good thing about being open and doing trauma work. You understand that journey is different. Sometimes people have bumps, sometimes people go smooth, and it's when you're open to it. So, Matt, this has been a great discussion. What do you want to leave us with?
the hardest thing you can ever do in terms of therapy is picking up the phone and making the first call. And if if the person doesn't call you back right away, call them again and then again and then again, because mental health people, they have trouble returning phone calls at times, so don't take it personally. And then also, be honest, be open, and just tell the therapist that you're working with what you need, and also check in with the therapist as well and say, how do you think this is going? I do that with my clients, and I encourage my clients to do that with me as well, throughout our work together, just so that we're both on the same page. And then, yeah, if anybody ever wants to reach out or have future discussions, or see if I'm able to practice in their state, I hold a SciPact certification, or credentials, so I can practice in numerous states. Feel free to reach out. You can certainly reach me or look me up at MatthewLovesCID.com, where you also have my telephone number, email, contact information. It's all up there, and we can have continuing conversations or talk about treatment, or I could direct you to somebody who might be a better fit.
You really do see how people play their roles in the world. That's one of the most impressive things that I when I met you, I was like, oh man, this guy really gets it, and it's kind of cool. So, everybody, if you want to speak to Matt or talk to Matt or just anything, like see him in therapy, the information is on our website and everything. And thank you for listening to this episode of Just Healing.